محمد موسى هو أحد مدرسين القلب المتخصصين في الكتروفيسيولوجي، وهو دلوقتي سيرتيفايد بالإهرا سيرتيفيكيشن، ودي حاجة احنا بنناشد الشباب كلهم ان هم يحصلوا عليها. و the first graduate معايا من ال EP diploma electrophysiology diploma of عين شمس which is 1 year after having your MD. ودي تعتبر الشهادة الثانية المتخصصة في علوم كهروفيسيولوجية القلب في جمهورية مصر العربية. الشهادة الأولى هي الزمالة المصرية، وشباب الزمالة بشكرهم إن هم يعني مكثفين الحضور وقاعدين بمزاجهم في هذا الميتنج. شكرا. ما تضحكوش.
السلام عليكم، بسم الله الرحمن الرحيم. نتكلم النهارده شويه هي actually it was better to be an interactive session but I will show some unusual ECGs in SVT. Let's start with the most talented one, is the Holter. Holter interpretation needs to see when the tachycardia begins, how it ends. You have to get any PVCs, PECs that interrupt the tachycardia and how the tachycardia interact with it. As we see in this strip. Okay. Actually, it's a short RV tachycardia. That's it. Let's make it simply. It's just an manifest pre-excitation with a short PR and delta wave. This termination of the orthodromic tachycardia through the accessory pathway. So it's a manifest pre-excitation and orthodromic tachycardia.
At the beginning was some P waves. Yeah.
Okay.
It started by two pre-excited beats, yes, and then there is a premature atrial beat on top of the T.
Okay.
صح?
That's it.
Conducting through the AV node, the accessory pathway is not active, and then maybe yes, it went into AVRT, or I can see a P wave on top of the T. Maybe I'm wrong.
Okay.
But common is common. If this is accessory pathway, so this is AVRT.
What about V1? This P wave actually on top of the T wave, but it can be short RP tachycardia, but longer than 100 milliseconds. And so it's going with the orthodromic tachycardia.
Common is common. Accessory pathway, AVRT.
And this is the diagrammatic view for the common sites of the accessory pathway around the tricuspid annulus and the mitral annulus. Some rare types of accessory pathway. The usual one is the Kent bundle. Unusual is the James fiber, which is responsible for the LGL syndrome, short PR interval without any tachycardia, or the Mohamed fiber, which commonest is the atriovesicular bypass tract. Let's start with the second case, a 7-year-old boy with palpitations.
أنا اللي هحل معاك.
اوكي اتفضل.
احنا الاثنين دفعة واحدة.
شرف ليا.
دفعة الدبلوم. Okay, this is 12 lead surface ECG, and the striking lead is V1. And as I can see, there is a negative P wave in V1. So it looks like atrial tachycardia.
That's it. Next is. Next is for the patient. Here is the clue: changing the B wave morphology in V1. So it's a long RP tachycardia with a different B wave morphology from the sinus rhythm, mostly an atrial tachycardia. Okay, let's follow this algorithm. Our patient had a stable regular narrow complex tachycardia. RB waves are detectable. Yes, it's detectable. We can start the vagal maneuver or adenosine. Ventricular rate is slow. Yes, so the B waves are detectable and the ventricular rate is low. What about the B wave morphology? It's an abnormal B wave morphology. It's going with the atrial tachycardia. What's the most common mechanism of atrial tachycardia? mostly enhanced automaticity. Okay. I will bypass this ECG. And these are the common types and most common types of the atrial tachycardia. Most common is in the right atrium, either the cavotricuspid isthmus, septal, perinodal, chroniosinus ostium, or the left atrium, left atrial appendage, and the pulmonary veins. 9-year-old girl with an incessant palpitation.
دي انا عارفاها على طول. العينه بتاعتي. we can see that the P wave morphology is completely abnormal, and this is evident in lead 2-3 AVF with a completely inverted P wave. And then we look at V1, a positive P wave. This is typical of coronary sinus origin of focal atrial tachycardia.
Okay. Is there another differential diagnosis?
A PGRT, because you have inverted P wave, long RP, inverted P wave 2-3 AVF, and positive V1.
Okay. Either chroniosinus atrial tachycardia or PGRTs.
But they are ablated near each other, يعني.
Okay, and on the same place. This is after ablation. It's very common for both atrial tachycardia and the PGRT to cause tachycardia-induced cardiomyopathy. I'm sorry. This is another example of PGRT. As we can see, negative P waves in the inferior leads, 2-3 and the AVF. There is a transient block in the retrograde limb here in the rhythm strip, and another BAC reinitiating the tachycardia. This is from literature. What is the mechanism of this tachycardia? It's a long RP tachycardia, different P wave morphology. It started with an atrial extra stimulation and it terminated with an atrial extra stimulation with a V without an.
You are delivering an extra stimulus, صح؟
Yes.
أنت اللي حاططها.
One extra stimulus is starting the tachycardia, and another extra stimulus terminating the tachycardia. It's suggesting of which mechanism? Enhanced automaticity or triggered activity or reentrant? Reentrant. It's reentrant. Atrial tachycardia is very rare to be reentrant tachycardia, but in this case, they ablated the atrial tachycardia with the earliest atrial activation preceding the P wave.
That was it, the stimulus capturing?
Oh, okay.
Yeah, it was capturing. Yeah. You have to, some events can stop on their own while you are delivering extra stimulus, and you have to make sure that what I am doing is effective. It's not by chance. Yeah.
Okay. A 13-year-old female with attacks of palpitation had this ECG.
حد من الزمالة بقى. رفاعي. أنا غلطت عادي يعني مفيش حاجة. إيه دي؟ أيوه. ها صوت عالي. Yes, so this is the first half is presence of delta wave, صح?
Yes, that's it.
And then what happens afterwards? اللي حصل بعد كده.
Manifest pre-excitation. Then a sudden onset of regular narrow complex tachycardia. So it's mostly an orthodromic AVRT.
سعيد يا همت.
The same algorithm, 12 lead ECG, rhythm is regular, P wave is not detectable. We will start with adenosine, carotid sinus massage. So our differential diagnosis is EVNRT, AVRT, sinus SNOD reentrant tachycardia, or some types of atrial tachycardia. Mostly here is the orthodromic AVRT.
حد من الزمالة همت ممكن تقولي انت شايفه ايه؟ همت
same patient.
همت يا سالي قومي اقفي. ممكن ميكروفون للشباب؟ لا مش سامعينك. نبيل الدلال. هو
الاول 3 شانل دول السيرفيس اي تي جي. هو واضح هنا ان في ليد 1 و2 في 1، وبعدين الابليشن ديستال على 1 و2 والبروكسيمال 3 و4. باين هنا على وسي اس 1 و2 ده الديستال مترتبه ديستال تو بروكسيمال. وبعدين هنا الهس اثرت الهس تمام. المفروض ان هو هنا في بري اكسايتيشن او
That's it.
ايوه. وبعدين بعد البري اكسايتيشن جت زي الضربه اللي هي الثالثه.
اوكي.
الاي دي شكلها بريماتيور يعني
تمام.
مش في البي اي سي او كده. وبعدين ايه اللي حصل؟ اتوصلت على ايه لونج اي بي تايم عن قبل كده، يعني شكلها اي بي نودال كوندكشن. وبعدين رجعت ريتروجريد، شكلها ريتروجريد على الاكسسوري في اي تايم لانه قصر. وبعدين الايرلي ستي اي على الايرلي ستي اي انا شايفه على سي اس 1 و2.
اوكي.
يبقى
فده
الاساس
ريتروجريد ليفت سايدد
سقفوا لها.
وبعدين بقى دخلنا في تاكيكارديا نارو كومبلكس شكلها اورثودروميك اي
كفايه سالي كفايه.
Okay, so the manifest pre-excitation على left-sided accessory pathway with the onset of orthodromic tachycardia.
شاطر يا سالي. سالي مدرس في جامعه المنصوره وسنه تانية زماله صح؟ اخر سنه لان الدكتوراه بياخدوا عندي في الزماله سنتين والماجستير 3 سنين. شكرا يا سالي.
Okay, this is a simple one, not that challenging. As
نوفل فين؟ نوفل جاوب.
في ميكروفون معاهم في القاعة يا دكتور ميفت. خلاص.
احنا هنا شايفين اتريال فلاتر 3 to 1 كوندكشن. البي ويف في في 1 بوزيتيف وفي الانفيريور ليز نيجاتيف. غالبا هنا احنا هنا مش تيبيكال فلاتر.
It's negative in 2, 3 and AVF, so it's going from down counterclockwise, and positive in V1. It's a typical atrial flutter. It's a typical flutter with variable block. Okay. This is a diagrammatic view for the counterclockwise typical atrial flutter, and this is the slow zone of the cavotricuspid isthmus, which is the target of ablation. What is the mechanism of this tachycardia? It's just simple enough. As we can see, it's a regular narrow complex tachycardia.
فين V1؟
No.
شاور على V1.
Okay.
فين V1؟
This is the V1.
Okay. في pseudo R؟
Not that present, but it can be seen in V3, so it's mostly EVNRT, as Dr. Mohamed said. This is the normal resting ECG of him. Okay, I get just a minute. Previous ECG was a traditional one. What's about this? In a 65-year male patient with a palpitation. As we can see, it's a long RP tachycardia, negative P wave in inferior leads, 2, 3 and AVF. So it's suggestive of what? Either AVRT through a slowly conducting accessory pathway. In 65 years it's not that common. Bejert, Berman junction reciprocating tachycardia is not that common in 65 years. So mostly it's atypical AVNRT.
سن كام؟
65 years. Atypical.
65؟
65 years.
اوكي.
It's atypical AVNRT.
واتريال تاكيكارديا.
Or atrial tachycardia is a common diagnosis.
اتريال تاكيكارديا.
It's complicated.
I think if I see this, I will not say this is atypical. I will say I don't know. I have to do some maneuvers. But if you look at lead 2, there seems to be some variabilities on the RR interval, and it seems to be the P to P interval is getting the shorter before the R to R interval. So I think I have to measure, because this could be a flutter in a 65-year-old.
Okay.
So when I see this 12 lead ECG, I have to do maneuvers just to make sure that the AV node away from the picture, just to see what is the underlying rhythm. So I will not just send the patient this for ablation without doing more maneuver, because this could be a flutter.
Okay. I'm with you. I'm getting it from the up to date. It's okay. It's already diagnosed atypical EVNRT. What I'm saying, the characteristic morphology of the P wave in the inferior leads 2 and 3 and EVF negative usually gives rise to the origin of the or the direction of the activation from below upwards. So a coronary sinus atrial tachycardia, atypical EVNRT, and all of them are ablated from the coronary sinus ostium. It's
Just
almost
to
the
assure
same.
you, the people that writing up to date, they are not always electrophysiologists. If you look at the V6, always remember, T wave, it is it's like your brother or your friend that doesn't change his shape. If you have some changes in the T wave, that something is going on and out of the T wave. So most likely the B wave is hitting it. So if you look at the V6, V5, I will say, if I bet, I would say this is a flutter more than the atypical EVNRT.
Okay. So it's for differential diagnosis.